Internal sphincter dysfunction is a common cause of fecal seepage or fecal incontinence. In most cases, the internal sphincter is intact but weak. And sometimes you can have defects of the internal sphincter as well. And currently there is no proven effective treatment for internal sphincter dysfunction, and we are here to describe to you the use of an injectable silicone biomaterial that is marketed as PTP implants in Australia. This stands for proctoplastic, and they comprise silicone microparticles in the carrier gel. The carrier gel itself is excreted by the kidney over the following 3 days and then replaced by fibrin and ingrowth of collagen tissues surrounding the silicone particles. The aim was to evaluate the medium-term results of treatment with injectable silicone implants to augment the internal anal sphincter in patients with fecal incontinence associated with internal sphincter dysfunction. We have 82 patients, more female than male. The median age was 66, and all of them had severe or significant fecal incontinence with a Wexner score of 10 or more. They all have a low or borderline resting anal canal pressure, and the patients were randomized to have the injection performed under guidance of endo-anal ultrasound in group A, or without ultrasound by palpation alone in group B. The complications were documented, and patients were assessed using endo-anal ultrasound, anal rectal physiology, Wexner continence score, the global quality of life using visual analog scale from 0 to 10, the fecal incontinence quality of life scale of Rockwood, and the SF-12 quality of life index. Both groups of patients have very similar demographics in terms of their gender, their age, the incidence of previous sphincter repair, and the incidence of previous anal rectal surgery. In most cases, the internal sphincter was intact as judged by endo-anal ultrasound, and in a smaller number of patients, there was in fact a defect of the internal sphincter. In about 60% in both groups, there was a prolonged pudendal nerve terminal motor latency of 2.6 milliseconds or more, and this is the cutoff in our laboratory, which uses 2 standard deviation, so it is a fairly stringent threshold. The median follow-up was 6 months up to 12 months in some patients. The silicone biomaterial was injected into the intersphincteric space or in the presence of a defect into the internal sphincter itself, and not into the submucosa or the anal cushion as was advocated by the St. Mark's group in their earlier small study. This is an example of a month of the injection, showing you the retention of the injected material in the intersphincteric space. Another patient taken at 3 months after injection, showing you again the retention of the injected material itself. The procedure was performed as a day case, and all the patients have a mild sedation with a local anesthesia. They all have some form of bowel preparation. We use altogether 4 doses. In the presence of an intact sphincter, the injection is into the intersphincteric space, 2 on the right and 2 on the left, and 1 anterior and 1 posterior. In the presence of a defect, 3 doses will be directed towards the area of the defect itself, and the 4th dose into the contralateral aspect of the anal canal to provide symmetry. In both groups of patients, there was a significant improvement in both the Wexner continence score and the global quality of life index as early as a month after injection, and that improvement continued to the last review with a median of 6 months. Looking at the same results on a graphical fashion, you can see that in both Group A and Group B, there was a sustained improvement in the first 6 months in both the Wexner Continence Score and the Global Quality of Life. However, in Group A, where the injection was performed under guidance of the endo-anal ultrasound, that improvement continued beyond 6 months to the last review at 12 months. And in Group A as well, there were more patients who have a significantly greater improvement in the fecal continence, as defined by 50% or more improvement in the Wexner Continence Score, 69% of Group A compared with 40% of Group B, and that difference was statistically significant. In both groups of patients, there was an improvement in the fecal incontinence quality of life scale, as shown on the median, the mean value here, and with a greater improvement again in Group A. And again, in Group A alone, there was a significant improvement in SF-12 quality of life scale, but not in Group B. As far as NOF rectal manometry was concerned, in both groups of patients, there was a significant improvement in the maximum resting pressure at the last follow-up at a median of 6 months. The cutoff in our laboratory was 40, so this is still just in the below the normal range, and there was a smaller but insignificant improvement in the maximum squeeze pressure. In about 60% of patients in both groups, there was a prolonged pudendal nerve terminal motor latency, suggesting the presence of pudendal neuropathy. That alone, however, has no impact on the functional outcome of the injection. The procedure itself was very safe. There was no infection in particular. There was no erosion of implant. There was no fistula. So in summary, injectable PTP implants were safe. They were retained at the site of the injection. The fecal continence was significantly improved 1 month after injection, but continued to improve up to at least 6 months. There was improved quality of life, improved resting endocardial pressure, and the results overall were better in Group A, where the injection was performed under guidance of endo-anal ultrasound. So in conclusion, injection of silicone biomaterial provided a marked improvement in fecal continence and quality of life in patients with internal sphincter dysfunction, despite the presence of pudendal neuropathy. And better results are obtained if injection of silicone biomaterial is performed under guidance of endo-anal ultrasound. At this stage, I'd like to thank my members of my team, and in particular my research fellow, and who has volunteered himself or his anus for part of the control experiment.
Thank you, Dr. Chandra. Take the first question. Ted Eisenstadt from New Jersey. You had a subgroup of patients who had on your preoperative evaluation a sphincter defect noticed, and another similar group who had a lateral sphincterotomy. Did that correlate? Were those patients with internal sphincterotomy those that had the sphincter defect? And did you look at those patients separately to see if that had an impact on your outcome, those patients that had a preoperative sphincter defect?
We have an indeed patient with a localized defect of the internal sphincter has an equally and slightly better results than we have got in the overall group. And that is the subject of a separate manuscript that we have submitted elsewhere.
McKeegan, Grand Rapids. Joe, do you have a sense that what's happening with the injection, whether you're creating a stenosis or whether you have manometric changes to show some lengthening of the anal canal, or both?
I think that in the main there's animal study on this to suggest that initially there's an inflammatory response followed by ingrowth of collagen tissue some 5 to 6 weeks after injection. In the human situation, I think there's no doubt in the beginning 4 to 5 weeks there is a slight inflammatory response, and which will create some improvement in outcome. There is no actual lengthening in the canal in the assessment that we have done physiologically, but as I've shown you, there was actually an improvement, a significant improvement in the resting pressure of the injection. And you can see the difference in the two groups, where one group was performed under endo-anal ultrasound guidance, the other one not, and the improvement was not sustained as vigorously in the other group where it was performed by palpation. and I suspected that this is because of inaccurate location and site or dosing of the injection itself, and it is much more precise to deliver your entire injection at the desired spot under endo and ultrasound control.
We have time for one more question. Green from Bremerton, Washington. On your ultrasound control, are you using the circumferential probe like we tend to use for examining the sphincter, or are you using more the longitudinal probe like the sector scanner with the biopsy guide?
I thank you for the question. This is actually an important question. And in fact, after the injection, you should not go on to do the ultrasound because the silicone can get dispersed. It will take about an hour or two before it will set. And what we have done is to localize the desired point of injection, either in the intersphincteric space or in the defect itself, using hypodermic needle 23 gauge. And that was inserted at 4 sites under control with endo and ultrasound. You then inject the silicone biomaterial and parallel and just next to that. And the hypodermic needle that you have inserted under endo and ultrasound control will give you the guide to the direction of the injection as well as the depth of the injection itself, because the point of injection should be in the upper inner canal, in the intersphincteric space, and it should not be in the submucosa. That accounted for all the problems that the St. Mark group has in terms of pain and erosion of implants.
Thank you, Dr. Chen.